Hello everyone. Today we'll discuss this case of acute pancreatitis, which is complicated by acute kidney injury. So we have this 39-year-old male patient was a known case of hypertension and diabetes mellitus, not on any medication. He presented to us with a chief complaint of fever and chills, and which was outside diagnosed as dengue. Now, mainly was his chief complaint was chest discomfort and the breathing difficulty. So because the patient was complaining of chest discomfort, we had done his 2D echo, which showed this inferior wall hypokinesia. So the patient was taken for CAG, but which came out to be normal. So along with this, all routine blood investigation were sent, and in view of this severe abdominal pain, severe epigastric pain, which was not subsiding, we have sent amylase lipase, which came out to be elevated. Further, we did CT abdo-pelvis for this patient, which was suggestive of acute pancreatitis. Patient creatinine started rising, urine output was dropping, so we have started with Lasix infusion. But then patient was not responsive to Lasix infusion, so we initiated SLAVE. These are the investigation of this patient. As you can see, the creatinine level is persistently rising. Initially, it was 1.4, then it became 2.4, and then it became 4.8. So issues with this patient was first issue was severe acute pancreatitis, then thrombocytopenia, which we thought it because of the some underlying sepsis or dengue itself. And the next issue was acute kidney injury. So we were thinking ki why this patient developed acute pancreatitis, and then we found that the possible this condition of the acute pancreatitis is possibly explained by dengue. So the acute pancreatitis is the rare side effect of dengue fever, and it is a link to the severe dengue hemorrhagic fever. Till date, there are very few case reports of dengue pancreatitis complicating dengue fever. So the common etiologies for acute pancreatitis include gallstone, alcohol, hypertriglyceridemia, trauma, and drug. And less common etiologies include periampullary diverticular, pancreatic divisum, periampullary mass, and infectious agents such as mumps, Coxsackie virus, and cytomegalovirus. So we excluded all these causes in our case by history, lab examination, and imaging test. And the exact pathogenesis of pancreatitis in dengue is not known, but it is caused because of the direct invasion of virus causing inflammation and destruction of pancreatic acinar cell, pancreatic damage due to dengue shock, and autoimmune response to islet cells, and development of edema of ampulla of water and obstruction to the outflow of pancreatic fluid. Now, the next question was why this patient developed AKI. So the possible explanation of this AKI is the patient might have some underlying sepsis or it is a complication of severe acute pancreatitis. So the severe, if a patient with acute pancreatitis develops AKI, then that itself carries very poor prognosis and the mortality rates are high. That is in between that is between 25% to 75% if patient is requiring RRT. So the exact mechanism of the AKI and acute pancreatitis is complex and not very well understood. But the key pathogenic process are a release of pancreatic enzyme with resulting impairment of renal microcirculation, hypoxemia, hypovolemia, intra-abdominal hypertension, endotoxin and cytotoxin mediated injury. And pathophysiology of AKI is a key pathophysiologic process involves the release of pancreatic enzyme from inflamed pancreas leading to autodigestion of pancreas and triggering cascade of events contributing to AKI. The activated enzyme and the protease release into circulation causes endothelial damage, which lead to the extravasation of the fluid from the vascular space. This leads to the intravascular volume depletion, hypotension, and third spacing of the fluid with increased intra-abdominal pressure. All these events ultimately lead to decreased renal perfusion, renal vasoconstriction, and hypercoagulability and fibrin deposition in the glomeruli. Now, role of pancreatic enzyme and their toxic substance. So, conventionally, hypovolemia and hypotension are considered the constant factor contributing AKI. Now, the recent studies shown that various toxic substances released from activation of kallikrein kinase system are involved in pathogenesis of AKI. And these substances include trypsin, chymotrypsin, bradykinin, histamine, phospholipase, prostaglandin E. Vasoactive peptide released during activation of kallikrein kinase system, which increases glomerular permeability and causes injury to renal tubules and interstitium. So phospholipases release decomposes phospholipid and lecithin of cell membrane. Lipid metabolites such as free fatty acid, acylcarnitine, and acyl coenzyme are membrane active factors that can destroy the cell. The activated complement system can produce C5b and it combines with the C6, C7, C8, C9 to generate membrane attack complex which destroy the cell. Now, the role of inflammatory mediators. The main inflammatory mediators implicated in severe acute pancreatitis, complicated by AKI cytokines, phospholipase A2, platelet activating factor, and nuclear factor kappa B and endotoxin. So, after this, the next day, the patient's blood pressure was dropping during dialysis, and the patient was extremely tachycardic. He was complaining of severe abdominal pain and tachypnea. So, due to financial reasons, the patient did not continue treatment in our hospital. But when he, when, but in this means when the patient was there in our hospital, he was complaining of severe abdominal pain. He was hypotensive, requiring multiple inotropic support, which raised the possibility of abdominal compartment syndrome. Now we will see what is this abdominal compartment syndrome. So abdominal compartment syndrome is the severe complication of severe acute pancreatitis, and it is because of increased intra-abdominal content by ileus, ascites, intra-abdominal bleeding, and most importantly, interstitial fluid accumulation due to increased capillary permeability due to endothelial damage. This increased intra-abdominal pressure of more than 20 mmHg reduces blood supply to abdominal organ, leading to low perfusion in the kidneys, causing AKI. So that and the main mechanism of intra-abdominal hypertension induced AKI is not clear, but intra-abdominal hypertension may compress and compromise the kidney blood flow in both arterial and venous vasculature, leading to decreased perfusion pressure, increased venous pressure, decreased venous blood flow, and increased kidney parenchymal pressure. This results in decreased glomerular filtration pressure, impaired microvascular function, and oxygen delivery, which precipitates into the ischemic kidney injury. Now, the next is hemodynamic alteration. In severe acute pancreatitis, blood viscosity and red blood cell aggregation index increases markedly, which disturbs the microcirculation in pancreas and other organs. This leads to decline in renal microcirculation, blood flow, and increase in renal vascular uh, resistance. The whole blood viscosity and afferent vessel contraction here may directly cause increase in glomerular resistance to lower renal flow. This increased viscosity and RBC rigidity affect the microcirculation of renal tubule capillary and causes renal cortex and medulla microcirculation disturbance followed by renal failure. So the intra-abdominal hypertension and abdominal compartment syndrome are established causes of morbidity and mortality. When interest in postoperative intra-abdominal hypertension after major vascular trauma and general surgery arose in 1980s, Overt ACS was the only clinical syndrome recognized, and decompressive laparotomy was the only definitive treatment. So it is important to understand that intra-abdominal hypertension, in contrast to abdominal compartment syndrome, is the continuum from asymptomatic elevation of intra-abdominal pressure to immediate life-threatening situation where dynamic evolution in both directions is possible. Therefore, it is difficult to identify triggers for intervention that may lead to complication or have adverse effect. The optimal treatment choice for specific patient with intra-abdominal hypertension and ACS should take into account three critical elements: the major IAP values, organ dysfunction characteristic, nature and course of underlying disease. Now the intra-abdominal pressure. The intra-abdominal pressure values has always been considered most important factor in in managing IH and ACS, and it should be viewed within its context. Factors that need to be considered in an individual patient include IAP measurement strategy, the exact expected baseline value of IAP. Then we need to consider how it is evaluating and the duration of time that the patient has already been exposed to IH. Now we'll first see how to measure it. So regarding IAP measurement and its interpretation. The reference standard for intermittent IAP measurement is via bladder with minimal instillation of the volume of 25 ml of sterile saline. IAP should be measured at end expiration in supine position after ensuring that abdominal muscle contraction are absent and with transducer zeroed at the level where mid-axillary line crosses the iliac crest. This generally means that IAP measurement is most reliable in completely sedated and mechanically ventilated patients. However, many intra-mechanically ventilated patients in ICU are at some stage of weaning process, exhibiting spontaneous breathing movement and possible patient ventilator asynchrony, pain, and distress. Similarly, critically ill patients who are not mechanically ventilated may be managed by non-invasive ventilation and they exhibit the respiratory failure, forced expiration, pain, or stress. All of the above process may lead to abdominal wall muscle contraction, increased IBP that may not reflect an increase in intra-abdominal volume. And it has been reported that in awake and non-critically ill patient without suspicion of IH, IAP can be as high as 20 mmHg without causing discernible organ dysfunction. And the impact of high PEEP on IAP is considered to be mild and adds 1 to 2 mmHg at most. As deepening of sedation or using numerous neuromuscular blocking agent may help to decrease intra-abdominal pressure and control IH for limited period of time, it needs to be considered that deepening sedation may have deleterious effect on hemodynamics. Switching from assisted to controlled mechanical ventilation may sometimes result in significant increase in intrathoracic pressure, even when muscle relaxation and expected positive effect on IAB will be negligible compared to its negative effect. Now regarding baseline intra-abdominal pressure values and dynamics. Baseline intra-abdominal pressure may vary in individual patients. Obese patients in particular have higher baseline intra-abdominal values, which in some cases may be higher than threshold for intra-abdominal hypertension. One review that IAP in individual with normal weight was around 5 to 6 mmHg, whereas it was much higher in obese patients with values above 12 mmHg and even above 14 mmHg in morbid obese. Other conditions associated with physiologically increased IAP include pregnancy, liver cirrhosis with ascites. Although this chronic IAP elevation may contribute to the chronic forms of organ failure, including chronic kidney failure in patients with congestive heart failure and obesity and pseudocyanosis cerebri in patients with obesity. Slight increases from the higher starting values may have limited implications in critically ill patients. As such, IIP of 16 mmHg may be insignificant if baseline value was 13, where it may cause organ injury if baseline value was 6. Unfortunately, the baseline IIP is usually unknown, and this effect is difficult to quantify. Now, the next important factor which plays an important role is the duration of intra-abdominal hypertension. In situation where exposure to intra-abdominal hypertension has already been prolonged, that means several days, or in case the delay IH diagnosis, the organ dysfunction may not be reversible as quickly or fully as in more acute situation. We hypothesize that intervention aimed at lowering IIP are unlikely to have immediate beneficial effect on organ function in this context, especially when IH has occurred and contributed to cellular organ injury. This highlights the importance of IIP monitoring in at-risk patients to avoid delayed diagnosis. On the other hand, one measurement of elevated IIP does not constitute the definitive diagnosis of IH or ACS, but the repetitive measurements are likely to ascertain through intra-abdominal pressure values and unmask the potential measurement error. Mild elevation of intra-abdominal pressure measured at one point is unlikely to cause organ dysfunction and seldom warrant immediate intervention but should lead to repeated IIP measurement. Now the next factor which plays important role is organ dysfunction. The second element that we need to consider is resultant degree of organ dysfunction, not to be secondary to IH and the rapidity with which it occurs. Many experimental studies have shown that subclinical organ injury develops at the level of IIP, previously deemed to be safe. As IIP increases, organ dysfunction will become more pronounced, and dose-dependent relationship between IIP and organ dysfunction have been demonstrated. Now, if organ dysfunction is developed, then we need to assess the severity. So, the most extreme and the urgent form of organ dysfunction in patient with ACS is inability to ventilate, which requires urgent action. Another very frequent form of intra-abdominal hypertension-induced organ dysfunction is intra-abdominal hypertension-induced AK. AK is usually firmly established with anuria and need for renal replacement therapy. Organ dysfunction may include hemodynamic instability, metabolic failure, gastrointestinal failure, or even intracranial hypertension. Multiple organ systems will fail, and the clinical picture can mimic many conditions like septic shock, hypovolemia, associated with multiple organ dysfunction syndrome. Organ dysfunction duration and dynamics. A sudden increase in intra-abdominal volume causing the sudden increase in IIP with subsequent organ dysfunction, and it warrants more aggressive treatment than situation where condition frequently associated with multi-organ dysfunction is diagnosed concurrently with intra-abdominal hypertension and organ dysfunction. In many conditions that are associated with IH, the pathophysiology of underlying disease may cause severe organ dysfunction. It is difficult to distinguish between intra-abdominal hypertension and this condition. Now, the etiology of IH and ACEs. The third element to consider in IH management is the etiology of elevated IIP, which allows the selection of the best possible treatment modality. The course of the disease that also need to be considered. An initial increase in IIP up to 18 mmHg after elective abdominal hernia repair may be well tolerated and could be just observed. Where same value of IIP in patient with severe acute pancreatitis and shock still need massive fluid resuscitation to preserve organ perfusion, presents a high risk of developing ACS and needs immediate attention and measure to control IM. All reasonable attempts should be made to ascertain the underlying disease leading to elevated IIP before starting treatment. Knowledge of the patient's medical history, the present condition, and full general and abdominal clinical examination usually offer the first clues. Direct imaging such as ultrasound and CT may also be considered. The risk factor for intra-abdominal hypertension and ACS has been described, and they can be largely divided into three categories, like increase intra-abdominal volume, decrease abdominal compliance, and combination of both. So, first risk factor is increase intra-abdominal volume. This can be caused by the increased intraluminal and extraluminal volume within abdominal cavity. The presence of increased intraluminal volume can be suspected based on clinical circumstances and diagnosed with medical imaging technique if indicated. Like gastric distension after gastroscopy due to gas insufflation, added colonic volume in C. diff colitis or severe constipation. Increased extraluminal volume may accumulate freely in abdominal cavity or localize in abdominal collection. Pre-abdominal air, fluid, and blood can be diagnosed easily by bedside ultrasound and can be evacuated by percutaneous catheter drainage. Extraluminal abdominal collection are mostly associated with underlying abdominal disease like pancreatitis, abdominal sepsis, and abdominal hematoma, and usually require abdominal ultrasound and CT imaging for accurate diagnosis and treatment. Now, the next is decrease abdominal wall compliance. Abdominal wall compliance is the measure of age of abdominal expansion, which is determined by the elasticity of abdominal wall and diaphragm. When abdominal wall compliance is decreased, and any increase in abdominal volume is much more likely to produce significant increase in intra-abdominal pressure. The risk factor for decreased abdominal wall compliance can be divided into three categories, including those related to body anthropomorphism and habitus, abdominal wall like burn, eschar, rectus sheath hematoma, tight suture, bandage, ventral hernia repair, prone positioning, and comorbidities like capillary leak due to sepsis, burn, trauma, and pancreatitis. Large volume fluid resuscitation, usually related to systemic inflammatory syndrome and biomediator activators, is one of the most important risk factors for development of IH and ACS. Due to its combined effect of increased intra-abdominal volume and decreased abdominal wall compliance due to tissue edema and abdominal wall. So the first two elements of triangle will determine whether or not two active attempts to decrease IIP should be considered. In what time frame these attempts should produce clinical relevant result, what level of invasiveness is required, and third element will determine which option will likely to produce the desired effect. So the first is patient with IH or ACS suspicion. So question one, is there need for intervention? And we should know why we are intervening. So we have to correctly interpret the intra-abdominal pressure and degree of organ dysfunction. Then the second is the timing of intervention is important. That is organ dysfunction dynamics and cause and versus effect relationship. And third is what is the preferred treatment. So this treatment line will be based on the cause of intra-abdominal pressure. So we'll see this one by one. So first is intervention required? Why to intervene? The decision to intervene will be guided by the presence of organ dysfunction caused by relevant increase in IIP in patient who has been diagnosed with condition that may be associated with IH or in which intervention is expected to have beneficial impact on IIP as well as organ function. The IIP value and evolution of IIP over time, the degree of organ dysfunction, are most important consideration. However, the measured IAP value should be interpreted carefully. If IAP is elevated in semi-conscious or fully awake patient and organ function is normal or improving, techniques to reduce IAP are probably less warranted or may cause unnecessarily complications. If IAP is normal after analgesia and sedation, IH is unlikely to be contributing factor to organ dysfunction. If IAP remains increased, the underlying cause of IH is likely, and additional diagnostic and therapeutic interventions are warranted. Now, how urgent is the effect of intervention that is meant to intervene? The urgency of intervention in the setting of IH depends upon the measured IAP value, the rate of IAP increase, and the degree of organ dysfunction. In most situations, the starting stepwise management should not be delayed, and some situations require immediate invasive intervention. In general, patient with primary ACS, the intervention is most urgent than the patient with secondary ACS, where clinician has more time to intervene. If adequate oxygenation and ventilation cannot be maintained, despite optimal ventilatory setting or circulation, it's severely compromised despite adequate fluid resuscitation and vasopressor support. Immediate decompression may be required irrespective of other intervention. If organ function is slowly deteriorating along with gradual increase in IAP, using technique expected to have slower effect on IAP may be considered, and if the potential for serious complication can be avoided by this strategy. Now, what is the best method of intervention? So, the method of choice for treating IH will be guided by both cause and that led to IH and degree of organ dysfunction. Knowing the cause of IH can help predict the effect of specific intervention on IH. The degree and dynamics of organ dysfunction should be considered to determine the desired decrease in IAP and time allowed to achieve it. Many techniques to decrease IAP have been described, and intervention may be aimed at lowering intra-abdominal volume, that is, intra and extra luminal volume, and improving abdominal compliance, or both. Now, regarding reducing intraluminal volume, evacuation of excess volume from GI tract can be accomplished by prokinetic and inhale. Decompression of gastrointestinal tract by nasogastric and rectal fluid or endoscopic decompression can be performed quickly and safely. But the only most proximal and distal part of the GI tract are accessible for easy intervention, thereby limiting their expected effectiveness in some patients. The IH and ACS, due to small bowel dilatation, may be difficult to treat non-invasively. Even if surgery is not required for treatment of underlying condition, the decompression laparotomy may be necessary, especially as combination of abdominal visceral edema and increased IAP poses the significant risk for bacterial translocation or even bowel ischemia. Now, regarding reducing extraluminal volume. Percutaneous catheter drainage can be used as definitive treatment in some cases, but can be used as temporary measure in cases where investigation of underlying disease is ongoing, but organ dysfunction requires urgent decompression, or after definitive treatment of underlying condition to treat any residual IH and ECs. Now, regarding improving abdominal wall compliance. Some conditions associated with impaired abdominal wall compliance can be easily corrected and enable fast and significant decrease in I. Burn ischar can be treated with ischiotomy. Tight bandages can be released. Body position can be changed. For other causes of decreased abdominal wall compliance, fast release is not possible or desired. In these cases, the other techniques to improve abdominal wall compliance can be attempted when indicated. Since small changes in intra-abdominal volume can lead to significant changes in IAP in patients with decreased abdominal wall compliance, bedside ultrasound and the removal of moderate amount of the ascites may offer relief of IH or ACS, even if main etiology of IH is decreased abdominal compliance, not amenable to non-surgical treatment. Now, the next treatment line is decompressive laparotomy. Decompressive laparotomy will decrease the intra-abdominal volume in relation to abdominal cavity and abdominal wall compliance. However, the consequences are considerable, and even with improved open abdomen management technique, this should be based on current knowledge and only be reserved for treatment failure. The intensivist should be aware that decompressive laparotomy can be severe ischemia reperfusion event, especially when IIP has been elevated for some time. The patient may require supportive measures to tolerate the intervention. After decompressive laparotomy, the patient should still be treated according to medical management principle, especially in terms of controlling the fluid balance and improving abdominal compliance in order to facilitate primary facial closure. So IIP should be monitored closely after decompressive laparotomy in order to prevent recurrent ACs. Thank you guys.